really will, and I think that speaks very nicely to all of our treatments begin at a ladder line and then move it up kind of step by step. And just recent publication or recent presentation of data in the hormone-sensitive setting. And what trials do you have your eyes on for maturing and being presented? Any particular trials?
Yeah, I think the trial
PSMA addition.
and the hormone-sensitive.
Hormone-sensitive, novel hormonal therapy plus or lutetium versus novel hormone. Sorry, lutetium plus novel hormonal therapy versus novel hormonal therapy in hormone-sensitive space. It's, I think every patient is asking and eager to learn about that, as are oncologists and nuclear and everybody. So
We are.
Yeah, and I think there's another phase 2 upfront PSMA just presented at ESMO, investigating de novo high volume metastatic prostate cancer, and patients were given 2 cycles of lutetium followed by docetaxel and versus docetaxel, and the primary endpoint I think it was PSA response, and it was a positive trial, and like
the upfront trial.
Dr. Shaver just mentioned about there's ongoing phase 3 PSMA addition is going on, investigating in addition to lutetium plus standard of care in hormone-sensitive settings. So I think the field is certainly moving to the right direction, using lutetium in a more frontline, or radioligand therapy in general in more frontline treatment.
Yeah, and I'll add that, kind of in addition to these, I had just was updated about an ongoing trial also. I think it's called PSMA-DC for delayed castration. So I think that'll be really interesting.
The oligomet.
So lower volume patients where they have PSMA positive on PET scan, but not evidence of disease on conventional imaging, which is so often what we're now faced with, I think, in our clinical practice. And so they're looking to see if using basically PSMA can allow for this delaying of having to go on hormonal therapy, which causes so many side effects. So I don't know how long that'll take to read out, but I'm excited for that trial.
I am too, because I think what's really interesting in the upfront trial also, it was some, maybe there's just been discussion that there's a difference between a castration-naive PSMA expression on a prostate cancer cell, which then we see on a PSMA PET. And then with castration therapy, the impact that has upon the PSMA on the cell. And so I also am very intrigued by PSMA radioligand therapy pre-castration, because that might be the greatest need that our patients express. Yes.
And I think there's been so many studies looking at trying to delay time to hormone deprivation therapy, and patients frequently ask about it. And so if the oligomet trial, which is radiation versus radiation plus lutetium, does show benefit to patients, it could be very meaningful with time off of hormonal therapy.
Yes. Have you seen any particular gaps or barriers to radioligand therapy in your practice? We have talked a little bit about distance. And what other barriers have you seen?
I think maybe the initial barriers, as we were one of the earlier centers, was just getting medicine, getting Pluvicto available. And so I think to your point of first needing the conventional scans, then needing the PSMA PET, then needing access to a drug. So I think just the logistical, getting everything up and running, and kudos to Dr. Schaefer here, who essentially did that at our center.
With much help from multidisciplinary care.
Yes.
But, I think that was the first, real barrier. And still to a certain degree, we're so used to starting chemotherapy, you can see the patient and start chemotherapy within a week. And so it's still just a different thought process of, okay, we need to be almost thinking about it in like a genetic sense. We need to get our germline and our somatic mutation testing now, because 6 weeks or 2 months from now, we might need to have, in this instance, radioligand. So I think it's just being thoughtful about what are the next steps, what's the patient trend, coming.
Right, because I think what you're saying is that you have multiple rate-limiting sequential steps, and as much as we have the ability to make those concurrent, yeah, so that we can execute kind of rapidly, if you will. Yes.
I'll add another barrier, which I was surprised by, but there's a lot of enthusiasm by patients for radioligands, but a small subset of my patients find out about our recommendations about avoidance for long periods with loved ones, especially pregnant females, young children. But especially older patients, I find, have spouses often that they are codependent on each other physically. Being near each other is important, whether their spouse has Alzheimer's or whether 3 days apart is a barrier. I have had numerous patients actually decline just for that recommendation. And so with counseling patients, we always talk about the recommendations and then it's a theoretical risk of a radiation toxicity to a loved one, of a second malignancy. Especially in older adults, we try to frame it as this is a recommendation, but it's not a legal commitment or anything like that. So we've been able to counsel on that. But I have found that some individuals elect not to do it because of the recommendation to avoid close contact with loved ones.
And that's a great point because it also ties into if you have a patient traveling from a distance. And how to logistically do that and who comes with them. Yes, so there are a lot of outside of the published data logistics that go on behind the scenes. And so I also appreciate and commend you for initiating the radioligand therapy group at Vanderbilt that we've kind of used it and worked with your workflow. And I know in the future that we're going to have choices of radioligand therapy. And so it's kind of like a veritable feast, if you will, when I think back 15 years ago and we could pick like 1 or 2 options. And here we have just laid before us a buffet, like the better term. And I guess, what are you excited about to see in just general radioligand therapy? Or what are you going to keep your eye on?
Yeah, I'm excited to see all the novel targets come out. I think what we're seeing certainly is thrilling. Many various molecules targeting PSMA, but seeing what success we already have, I'm also wondering now, will there be additional surface markers that we'll be targeting? I think I saw a diagram recently, and this was not, of course, just for prostate, but like over 250 different radioligand, and that includes combinations of the targeting molecule, different linkers, and then different radioisotopes. So that's really what I'm excited about. I don't know.
Yeah, no, totally agree. Dr. Beckerman's comments, and we know there are so many nuances there in terms of the radioligand therapy. There is small molecule nowadays we have targeting PSMA. There is also in developing antibodies targeting PSMA as well. There are alpha emitters, there are beta emitters, so there are so many choices nowadays. And on top of that, today we're talking about prostate cancer, but there's also radioligand therapy in the renal cell carcinoma currently undergoing. So it's really exciting field to see the new treatment options for our patients.
It really is.